Welcome to another episode of Ignite Health, brought to you today in collaboration with Caribbean Surgery. This program is dedicated to empowering you, our audience, with trusted medical information, expert insight, and practical advice on how you should take control of your health. I'm Dr. Surendra Persaud, the Medical Director of Caribbean Surgery, and your host. Each week, we bring you important health topics, answer common questions, and help you understand when and why it's time to seek medical care. Because informed choices today can lead to healthier lives for you tomorrow. So today our topic is colorectal cancer. And why should we care about colorectal cancer? Now obviously, first before we talk about what is colorectal cancer, what does the term colorectal mean? Colorectal is two words put together. So we're talking about the colon and the rectum. When we're talking about the colon, we're speaking about the large intestine is what most people speak about, and the rectum. So it is part of our digestive tract. If we go all the way back to primary school, we would have learned that the primary purpose of the colon is to extract water. So when food comes from our little intestine to our colon, which is on the right lower quadrant, so the right side of our body down to where all of us know where our appendix is. So that is where the little intestine enters or changes to the large intestine. And the large intestine or the colon comes up the right side, goes across the body, goes down on the left side, makes what's called an S loop, we call it sigmoid, and then there's the rectum. So the colon main purpose is to extract all the water that we have added and the liquids we have added to the food. And the rectum is sort of a store because it holds our stool there, so when it's appropriate and timely, we can go to the bathroom and have a bowel movement. Now, colorectal cancer are therefore cancers where the cells on the inside of the colon or the rectum become cancerous. Now, as we discuss cancers of the digestive tract, it is important to recognize that the digestive tract is essentially a long tube. It has various organs along it. And that tube has an inner lining, it has a thickness of a wall, and it has an outside. So items that we consume in our food and our beverages are going to be the largest contributors of risk in terms of causing these cells. So colorectal cancer is a disease where abnormal cells begin to grow on the inner lining of the colon and rectum. And over a period of time, those cells will develop into a cancer. So as we're discussing colorectal cancer, or as we discuss any condition, the first question is, why does it matter? And the sad reality is that if you look at Guyana and the Caribbean today, colorectal cancer is on the increase. Look at the visuals, Google it, and you will see that colorectal cancer in the Caribbean is increasing. And this is why we should be very, very concerned about this. And so I encourage everyone, read, educate yourself, and understand why it's important. On a separate note, let us distinguish between colon cancer and rectal cancers, because although they are part of the same digestive tract, they are very different in their anatomy and how we manage them. So when we speak about the colon, we are essentially talking about the large intestine that starts around where all of us are familiar with where our appendix is, and it goes up. It's called the right colon, transverse colon, descending colon, and the sigmoid colon. And that's where the stool is transiting and our body is extracting water so that the stool we pass out is less liquid and more solid. The rectum, on the other hand, is that lower portion of the intestinal tract between the colon and the anus that serves the purpose as a reservoir. It holds our stool for where it's more convenient. Now, because the rectum can be accessed through the anus, the way we look at rectal cancers is a little bit different. And also because the areas of the rectum are more fixed. we have the option of going through the anus to diagnose as well as to treat certain cancers. So although we bundle colorectal cancer together, just know that there are subtle nuances to the manner in which we approach diagnosis and treatment. Now, what are the sort of broad strokes? If you think about your colon and something growing inside of it, something that starts like a polyp. What is a polyp? All of us know what a skin tag is. Well, if you have a little tag like that, now this is small. It is a few millimeters. There is no way as this is developing, you are going to be able to appreciate that. So if we are going to make significant advances in reducing colorectal cancer, we're going to talk a lot more about screening. But let's come back to some of the significant differences. So we talked about the colon, we talked about the rectum, we talked about now colon cancer and rectal cancer. We generally treat these similarly. However, because rectal cancer can be accessed through the anus, some of the tools we use in the management of it are slightly different than we do for the colon. So the colon starts with the large intestine, rectal cancer is from the rectum. Now, many persons will confuse hemorrhoids, constipation with colorectal cancer. Hemorrhoids, very significantly different process. Hemorrhoids are limited to just a small area in the anal canal, not in the colon or the rectum. So a completely different condition. But it is one of the conditions that you should come to your doctor with. Now, who is at risk for colorectal cancer? We say that everybody who is over the age of 50 is at a risk for colon cancer. Now, what is troubling is we are seeing an increase in the incidence of colorectal cancers in persons under the age of 50. So you need to speak with your physician. If you have a family member who has had colorectal cancer, essentially you need to be having screening for this about 10 years prior to the age at which that family member discovered. And we'll explain why 10 years. So everybody over the age of 50, everybody with a family history of colorectal cancer. If you yourself have had a history of colon polyps, diabetes, or any conditions that we call inflammatory bowel disease. Okay? If your diet is low in fruits and vegetables and high in red meat, again, as I've said before, in Guyana we have no excuse for that. Our diets should not be low in fruits and vegetables. Sedentary lifestyle. Again, no reason for us to do that. We all have warm weather, ample walking areas. We should be getting out and moving. And alcohol and tobacco use. So again, quit smoking, reduce your alcohol intake. Which then obviously leads to the logic behind the next question. Does lifestyle matter? And the answer is absolutely. If you are, and why is that? As we are more active, our gut functions better. But in the Caribbean, we like our fried foods, we like our processed foods, so that obviously increases our risk. So we need to really pay attention to what we are consuming. And the closer the food is to the plant, that is obviously better. The less processing, the better. Now, what are some of the early warning signs? Again, the main focus of this talk is going to be on not waiting for the warning signs, but getting the screening done. And we will talk about the risks and benefits of that screening. However, if you notice bright red blood or dark red blood in the stool, that is a red flag, literally, a flag that you need to speak to your doctor. If you're having changes in your bowel function, most of us have a very predictable manner in which we get up, have something to eat, go to the bathroom. If you notice that is changing, you're getting diarrhea, you're getting constipation, the stools are changing and they're becoming narrower, or you're having more difficulty, those are things to be concerned about and things to speak to your doctor. If you go to the bathroom and you have had a bowel movement, but you feel as if you haven't completely emptied, that is of concern. If you're having unexplained stomach problems, bloating, cramps, okay, those are concerns. What about if the disease is advanced? And again, our goal is to avoid this happening. If you have weight loss that you cannot explain, if you are not trying to lose weight and you are losing weight, that is very, very concerning and requires you to seek the assistance of your doctor. Pain that is persisting in the abdomen, you don't know why. You're just having this ache, dull pain that's not going away. Vomiting, because again, the intestine is a tube. And if something is blocking the tube here, then it's going to back up here and you're going to throw up. What causes colorectal cancer? And this will hint back to the 10-year we talked about. All colon cancers generally start as a small polyp. What is a polyp? It's like a skin tag, but this is something that's on the inside of the intestine. And it's small, okay? Now it takes quite a few years for that polyp to change, the cells in this polyp to undergo a variety of changes that then leads it to become cancerous. And so genetics, diet, lifestyle will all play major roles in whether that polyp becomes a cancer. Now, not every polyp can become a cancer, but all cancers of the colorectal system, or the vast majority of cancers that we're concerned about in the colorectal system, start as polyps. So you can already recognize that where we'll be leading you to is how do we find those polyps early and get rid of them. And that leads into the question of prevention is better than cure. Or prevention is the best way, to cure yourself of this. So today, we consider colorectal cancer to be a preventable cancer. I'll say that again. We consider colorectal cancer to be a preventable cancer. And the primary reason we say that is that the polyp, which is the starting point, we have technologies and procedures to find that polyp and remove it from your body before it can become a cancer. So let's talk about the diet and the habits first. Eating more fruits, vegetables, increasing the fiber content. That reduces your risk. Reducing red meats and processed foods, avoiding smoking, avoiding alcohol, and staying physically active. Screening. So let's talk a little bit more about how we detect colon cancer, and colonoscopy. The older method, which is still used today and still has value, is we are looking for blood in the stool, or we are now looking for changes in DNA changes. So in developed countries, a stool sample can be assessed for DNA markers to suggest that. CT scans are spoken about, but the gold standard test is what's called a colonoscopy. No one looks forward to having a colonoscopy. But the most difficult part of the colonoscopy is not the procedure, because everybody is asleep during the procedure. The hardest part of a colonoscopy is the preparation, because you have to drink quite a bit. You have to drink about 4 to 5 liters. 2 liters of horrible tasting liquid, because the salts that we put into this, remember, in order for us to see the inside of the colon, we've got to let this colon be empty of stool and washed out. So there's a packet of these salts which we give you, and you dissolve it. I've had doctors who have had this procedure say to me, please recommend your patients put it in like Gatorade or one of these types of drinks, something to enhance the flavor. And it comes usually with an orange flavoring or a lemon flavor. But essentially, that is the most challenging part. You're at home, you start this at night, and you start drinking this liquid. And you will eventually go to the toilet and you will be flushing out your large intestine. And you finish that process about midnight. You go to the hospital in the morning. You go up to the operating room or the procedure room. An IV is placed in your hand and you will be asleep. and the entire procedure is done and you're asleep. You will have, once you have been adequately sedated, you will have no recollection of the procedure. The procedure can take anywhere from 30 minutes to maybe 90 minutes, depending on the difficulty. But you're passing a tube that's essentially about the size of your finger and quite long because it's got to get all the way around. So the tube goes through the anus, up the rectum, around that part of the S colon we spoke about, up the left side, across and down. And as the doctor is doing that, and as the doctor is looking, they're looking to see the inner lining of the colon and the rectum. And what we're particularly looking for is the pattern of the blood vessels. Are there any pockets, which is a different condition called diverticulosis? And are there any polyps? Are there any growths? Any polyps that are found, the vast majority of these polyps can be removed at the same time with the same instrument. We have a fancy set of tools, little things that can take pinch biopsies. We have things that look like snares, which we can heat and we can trim the polyp off. And so this is why we consider colorectal cancer to be a preventable condition. As we mentioned, all of these colorectal cancers start as polyps. You have the colonoscopy, you find a polyp, you remove the polyp, there goes your risk of colon cancer. It's gone. It's out of your body. It has been removed during the colonoscopy. Okay? So who should be getting tested? As we spoke about, everybody over 50. But because we are now seeing an increase in persons under the age of 50 who are getting colon cancers, we are now dropping this to about 45. So 45 and above. If you have a family history, definitely earlier than that. Speak to your doctor. Persistent bowel changes, blood in the stool, history of polyps. All of those persons should be getting screened. You will read, as everybody, we encourage everybody to go online. There are risks attached to a colonoscopy. So we are always looking for new technologies that are less risky. So there is something you will read about called a CT colonography. And this requires the same level of preparation. But rather than having a tube passed up, you go and you have essentially a CAT scan, which is radiation, X-ray machine, and they can get very detailed images. However, it has still recommended by the societies that the gold standard is the colonoscopy. And we reserve the CT test for individuals who have risk factors that are too high to have a colonoscopy. What are the treatment options? So, again, if we do, most of the time the diagnosis will be made on colonoscopy. So, either during screening, something is found. Hopefully it is found very early and the treatment is just the removal of the polyp. And there is an entire body of science that speaks to what types of polyps, what to do with those polyps, if the cancer is in the tip of the polyp or in the neck of the polyp. There's an entire battery of science behind that your doctor will speak about. And the treatments would obviously vary. If you have a cancer where it is now it requires a next level, that treatment options include surgery, chemotherapy, radiation therapy, newer immune therapy. And the type of surgery, the type of chemotherapy, the type of radiation, the type of immune therapy varies. But essentially, broad strokes, chemotherapy is a chemical, a drug that is given to you and travels through your whole body looking for cancer cells. Radiation is to a particular area. Immune therapies are our new weapons, and it's meant to be a more targeted therapy. Now, as I said, colorectal cancer is considered today preventable. So if we find that polyp and we remove that polyp, the chance of that polyp becoming cancer is gone, zero. Okay? Can you develop other polyps? Of course. But the time frame between the development of a polyp and the development of cancer is about 5 to 10 years. And so today we recommend colonoscopy to be every 5 to 10 years. So if we are doing the screening properly, no one will develop colorectal cancer. Unfortunately, people still come late. And so then you are forced to do surgery, chemotherapy, radiation, and we cannot save everybody. The survival has improved, but it is based upon how early we find it. I know personally persons who have had colon cancers and are considered today disease-free from the therapies that they have gotten. But we still find people where the cancer is too late, it has gone outside of the colon or the rectum and it has spread to other organs. Very, very difficult at that point in time to get ahead of it. So what is the outlook for the Caribbean? Survival is highest when we find it early. Okay? So what are the sort of broad take-home messages I want you to have? We need everybody to be screened for colorectal cancer. It is the single best way of reducing your risk of dying from colon cancer. So everybody, male and female, above the age of 50. As I've mentioned, because of the increasing incidence of colorectal cancers in younger persons, we are now looking at 45 and older. If you have a family history, definitely you need to speak to your doctor. Quit the tobacco, reduce the alcohol, more fruits, more vegetables. Early detection is very, very important. Physical activity, okay? So, the final take-home message, I want you to quit tobacco, eat more fruits and vegetables, keep yourself active, see your doctor, and understand the rules for this are very, very clear. So on that note, I am encouraging all of you to pick up the phone, make an appointment with your doctor, and ask them when and what is the most appropriate procedure that you should have for reducing or determining your risk of colon cancer. On that note, do have a good day.